Okay, we're live. CT of the appendix. Hello, everybody. I meant to comb my hair, but I did shave, right? Um, First of all, today's Passover. Happy Passover to everybody. Happy Easter to those who'll be, I guess, Good Friday's tomorrow and Easter Sunday's coming up. So happy to everybody, whatever you're celebrating or whatever you're not celebrating. This is on CT of the appendix. Just a few little things. We never mentioned the appendix. Everybody forgets about it. CT is one of the strong apps for appendicitis. It was one of the things that really everyone did all the time on every patient. Now on pediatric patients or younger females, patients who are pregnant, you could use MR. Ultrasound's also been used with varying degrees of quality. The thing about CT about the appendix is we talk about appendicitis inflammation. The appendix is dilated, there's a stone, there's thickening of the wall, enhancement of the wall, and stranding around the appendix. Sometimes the biggest challenge you have is finding the appendix, particularly patients with who are very skinny. It's hard to see the appendix. Sometimes, you look for appendix, you don't see it, and then of course the patient has had an appendix removed, but sometimes it's hard to see. You want to use IV contrast because then the enhancement of the appendix is something that becomes very valuable. When it's hyper-enhancing, it means it's inflammation. It's easier to see the appendix with IV contrast than without it. We published an article way back when that shows if you look at coronals, it's much easier to find the appendix, particularly on skinnier patients where it's kind of stuck in between the cecum, terminal ileum. On the coronals, it lays things out a bit better. And when you have unusual positions of the appendix can come medial, it can come inferior, it can go superior, it can go lateral. It's much easier to recognize where the appendix is and where it's coming from. So things we look for: is the appendix inflamed? Clinical history, presentation. Okay, that makes it easy. Then we look for complications. Is there a perforation? If you have a perforation, you may not want to do a laparoscopic procedure. You may want to do it open. So looking for inflammatory collections. You look for tracking toward the liver. Patients with diverticulitis or appendicitis can develop liver abscesses if things are delayed in terms of diagnosis. So when you're doing a CT for appendix, you look carefully, look at the liver, you look at the kidneys, you look at the pelvis, you look everywhere but the appendix, then you look at the appendix. And so hopefully you can put all of that together. We talk about appendix and malignancies. Mucocele of the appendix, usually it's the tip of the appendix. It's usually a soft tissue mass, often enhancing. It can perforate and you get pseudomyxoma peritonei. Patients with mucocele of the appendix, usually it's an incidental finding in the sense the patient's presenting with appendicitis and they're getting surgery, and when the surgeon operates, they see a soft tissue mass, path comes back a mucocele. Every once in a while it comes back a carcinoma. So there are malignancies related to the appendix. Mucocele is the one we typically think about, and again in those patients carcinomatosis becomes very common, but it can be a difficult diagnosis, particularly when the mucocele is small, and then it's more likely a path diagnosis. In terms of accuracy of appendix, it's well over 90%. If you see the appendix and there's no inflammation, there's no abnormal enhancement, there's no stone disease, it's a normal appendix. Other times it can be somewhat challenging. Specificity, sensitivity, 88 to 100% depending on the articles published. And again, technique is most critical. Some people say maybe you should do a focused appendix exam, just scan this much, but I think we all have learned that when you have pain, right lower quadrant, although you may think it's appendix, it could be kidney, it could be liver, it could be retroperitoneum. So doing a low dose scan or a properly dosed scan of the entire abdomen and pelvis will help you make the right diagnosis, whatever the diagnosis is, and understand the potential for complications. So that indeed works out very well. The question about using oral contrast, you may remember in the old days, we would give oral contrast and wait 3 or 4 hours. Okay, that doesn't happen anymore. You may remember that the groups in Boston, particularly Mass General, were giving rectal contrast. We refused, but they did it and they annoyed everybody, and some other people had to do it. But used to give rectal contrast to distend the right colon and the appendix, potentially release the right colon. We never did that. We haven't done it, and no one does it, so that's not going to be an option. So typically it's water, IV contrast. Look at the axials, look at the coronals. Sometimes the sagittals are helpful, particularly when there's a retrocecal appendix. But again, IV contrast is what you really want to do. Single phase acquisition. You don't need two phases. You can see inflammatory changes in the cecum secondarily. You also want to be careful you're not dealing with like a process like Crohn's disease where there's some inflammation by the appendix and cecum and distal bowel. So at times it's not going to be perfect. So complications I mentioned, perforation is one. You have an abscess. Typically you'll go to an open procedure when you do that. We talk about peritonitis as a possible complication. We talk about bowel obstruction, inflammation, and the patient presents with a small bowel obstruction. We talk about septic seeding of the mesenteric vessels. That's in the articles, but it's pretty rare. We talk about air in the appendiceal wall, like a gangrenous appendicitis. That also is going to be very rare. So again, there are some unusual things. In terms of differential diagnosis, appendicitis, mesenteric adenitis, cecal diverticulitis, one of my favorites, appendix epiploica. Also things like omental infarcts, inflammatory bowel disease, particularly Crohn's disease, can be a great simulator. And also terminal ileitis, infectious terminal ileitis like salmonella infection can also clinically and radiologically be somewhat of a challenge. I mentioned appendiceal mucocele. You can have carcinoma of the appendix. It can perforate. And again, it's a challenging diagnosis because on CT, looks like a big abscess, looks like a perforation. You may not think about appendiceal carcinoma. Obviously, you look at the liver. If you saw liver lesions, you would think about it, but it's not something you typically think about. So CT is an ideal study for appendicitis. Again, you can do a low-dose study. Patient's pregnant, young female. You can do MR. Many places do. We do as well, but not 24/7. Pediatric patients, MR or ultrasound. But often when you're uncertain, CT is where you end up going anyway. So with that, I'll stop there. Some of you read in the paper, there was some articles lately. There was a meeting in New York where one of the administrators said that they're going to replace all the radiologists with AI. That could happen. What you need to have is better articles where you replace the administrators with AI, because AI doesn't have to be that smart to replace most administrators. I wish I said that. Anyway, next week, Thursday, I will discuss, Lily and I spoke already, we're going to look at that topic about AI replacing radiologists. And a few people spoke to me who are med students. Should they go into radiology? Okay, things will be good for a few years, but what about 5 years or 10 years? They won't be finished for 5 or 6 years. What about 10 years or 20 years? Will radiology be something viable, or will it go away or be markedly decreased? So think about that. Think about questions you want to ask. I'll start the conversation, but let's see what you guys have to say. So with that, have a great day and see you all soon. Bye-bye.